Okay, well, thank you very much. My name is Mike Postow, and I'm a melanoma medical oncologist. So I don't know if how many people were in the prior session where we were talking about immune therapy toxicities, but I'll cover a few of the main concepts here again. But this talk will focus mostly on pneumonitis, and the topic was assigned as rare toxicities, but I included lethal toxicities because I think it's such an important issue to discuss. And having been a melanoma medical oncologist where we tested these immune checkpoint blocking antibodies for many, many years, we've caused, unfortunately, many toxicities, and that's been something we've been very grateful for everyone's helping us trying to understand better. Here are my disclosures, mostly through work for various advisory board participations and support for clinical research at our institution. When we think about immune therapy toxicity, this is a slide I showed before. Essentially, any organ in the body can be inflamed. And the lungs were something that in the ipilimumab era, when we were giving CTLA-4 blockade as the first immune checkpoint, I don't think we realized how much pneumonitis was really a problem. And it wasn't until PD-1 came about that pneumonitis started to be really a big issue. And I don't really know why that was exactly the case. You can still have ipilimumab pneumonitis as well, but I think with the vast number of patients getting PD-1 antibodies increased that denominator so large that we started seeing some of these toxicities like pneumonitis, which is rare, but it does happen. And it's actually interesting, if you look at the rates of pneumonitis in checkpoint inhibitor-treated patients, it's not necessarily that much higher than pneumonitis that one would see with other common chemotherapies that can cause pneumonitis or even some tyrosine kinase inhibitors. But pneumonitis is just what we would think about. It's inflammation of the lung. And this was a patient that we had taken care of many years ago with melanoma. And at that time, we were giving ipilimumab first. This patient had 2 doses of CTLA-4 blockade with the checkpoint blocking antibody ipilimumab, and then had nivolumab. And you can clearly see from February of 2011 to March of 2011, about a month after this treatment was given, really significant, obvious pneumonitis that you can see on a chest CT scan. And of course, this patient was symptomatic, which prompted that CT scan. But anything really can be pneumonitis. And one of the interesting questions that has been in this field is whether there is a certain kind of inflammation that is associated with checkpoint inhibitor pneumonitis. So when you block PD-1 or PD-L1 or CTLA-4, does a certain type of inflammation happen in the lung that may be distinct from other hypersensitivity or interstitial lung diseases. And a case series was conducted. A number of case series on this topic have been published at this point. This was one that Jarushka Naidu, who was one of our fellows at Sloan Kettering, put together, supervised by Matt Hellman in our thoracic lung group, looking at about 40 or so patients with different types of checkpoint inhibitor-induced pneumonitis. And I'll just highlight a couple of their main findings from, I think, this is the largest series of pneumonitis that I'm aware of, is that really anything could be pneumonitis when you look at a CAT scan. And I know that's not really helpful because we want to we have a patient that's getting immune therapy, they get short of breath, we get a chest CT, we make sure that they're not having a pulmonary embolism because that can be a confounding issue. And we want to see that there's something that says, oh, this is checkpoint inhibitor pneumonitis, but the problem is anything can really be checkpoint inhibitor pneumonitis. And these show a number of different radiographic patterns that one could see in pneumonitis, 5 different types, ranging from cryptogenic organizing pneumonia-like, kind of the ground glass opacities that many of us see on chest CTs all the time, to interstitial changes, to hypersensitivity. And if it didn't fit into any one of those 4 categories, there's the last category, which is pneumonitis not otherwise specified. So I think the key takeaway from this is that it can be anything on the chest CT, and it can be checkpoint inhibitor pneumonitis. So this is a diagnosis of exclusion. If you don't have an infectious pneumonia, and I know that's often sometimes hard to tell, but if you don't have an infectious pneumonia, then you have to think about the possibility of pneumonitis. Now, how do you really try to get to this diagnosis? Of course, someone often will have cough or shortness of breath, and then you have to do a workup. But if you're thinking about checkpoint inhibitor pneumonitis, you can think a little bit about the timing of when these kinds of side effects do happen. In this case series of around 40 or so patients of pneumonitis that we put together, you can see in the middle here, if you look down through the different rows, looking at the top first of those blue triangles, those are all of the 43 patients that had pneumonitis and when their pneumonitis began. The median time of onset of the pneumonitis in this group of patients was a couple months into the treatment. So not immediately right away, but a few of those blue triangles did happen very, very early. So Most patients happen a little bit later, but you have to be aware that they often do happen early. And the tricky thing about this is even after 180 days, extending even to 360 days, that's a year on treatment already. There are a couple of cases of pneumonitis that still happen late. So even if you've gotten through a whole year without pneumonitis, you can still have it coming up a little bit later. And there really was no major difference between higher grade pneumonitis, grade 3 or higher, and earlier grade pneumonitis, grades 1 and 2, in terms of when these set in. I would caution the grading of pneumonitis is a little bit subjective. Grade 1 is asymptomatic or clinical, no clinical symptoms, but radiographic diagnoses only. So these are the patients that you pick up pneumonitis incidentally on CT scans that you're doing for other reasons. So what to do if you have pneumonitis? If you only have radiographic changes, grade 1 pneumonitis by definition, you can safely monitor those patients without additional checkpoint inhibitors and see if it resolves. Mild or more severe symptoms usually needs at least 1 milligram or 2 milligrams per kg of prednisone. How do you decide exactly how much steroid to give a patient? I can tell you that there are all these guidelines that are out there, but as long as it's at least 1 milligram per kilogram, I think you're okay. If you get really scared, then you can give 2 milligrams per kilogram, and it's not so much more scientific, unfortunately, than that. There was a discussion earlier today about the role of bronchoscopy, and I think that's something that hopefully we can kind of continue to talk about through the panel discussion. It's not so clear exactly who needs a bronch and when. I do like to do them in cases where the diagnosis is not clear, but it should not be something that you feel that you have to do before you initiate immunosuppression, especially in a symptomatic patient. So don't delay the initiation of steroids because pneumonitis can be fatal. And I think it got a lot of attention due to the fatalities in the original phase 1 study that was published in 2012. And that's why there's a lot of attention on this issue. So bronch, yes, something to consider, but not instead of starting immunosuppression if your clinical suspicion is high. The other thing I think to think about for pneumonitis is that while you're tapering the steroids, pneumonitis can recur, and it's really important to consider the possibility of recurrent pneumonitis on steroid tapers, and that patients sometimes have to go up on steroids or need an additional immunosuppressive agent like infliximab while they're being treated for pneumonitis. Keep in mind if patients are on steroids for a month or longer at 20 milligrams of prednisone daily or more to prophylax against PCP pneumonia, because unfortunately we have had patients that have developed PCP pneumonia while they're on steroids for pneumonitis, and then you're really confused. Is it PCP pneumonia that's bad, or is it worsening of the pneumonitis as you're trying to taper off of the steroids? And it's often very, very hard to tell, although you can send beta-glucan and other markers to try to make that diagnosis if you wish. This is a table from the paper, and I don't want to go through all the details, but I think this is an interesting way to talk about how these patients were generally managed and what their outcomes really were. And that if you look at the top row here, this basically shows the highest CTCAE grade and then how we were able to get away with treating some of these patients. And so each of the different columns talks about how the treatment was administered, either treatment hold, oral corticosteroids, IV corticosteroids, or additional immunosuppression. And just a couple take-away messages here. If you have grade 1 pneumonitis, most of those patients were okay just holding treatment and not getting steroids. Only 12% of these patients had steroids. So if you find pneumonitis on a CT scan and the patient's asymptomatic, you don't have to treat those patients with steroids, just follow them carefully. Of course, for the symptomatic patients grade 2 or above, all those patients had either oral or IV steroids. And I think that's the main message, in that how the patients did, mostly with holding. If you have grade 1 pneumonitis, 100% of those patients completely resolved with just holding drug for the most part, although a couple got steroids. So I think the key is, if it's just something you see on the scan, not to panic if patients aren't symptomatic, hold the immune checkpoint blockade till it resolves and the patients get better. As we were talking about before, patients can have infections in the lung that really muddy the waters here. And this is a patient I took care of that was on immunosuppression for other reasons and then developed respiratory complaints, ended up having an Aspergillus fumigatus infection that needed to be treated with antifungals. So really keep your eyes out and think about other possible infectious complications, especially if someone's been immunosuppressed for a little while already. Now, rare or lethal toxicities are another important issue. We've talked about pneumonitis as one example of a rare and lethal toxicity. Rare meaning it usually pneumonitis comes in a couple percent points in terms of incidence. But this was a study that was conducted by Doug Johnson and others at Vanderbilt, looking through large numbers of data set, meta-analysis of trials, pooled data from a number of academic institutions, and a pharmacovigilance database called Visualize, where they looked at all the different patients that had fatal toxicities and characterized what kind of result was their fatality, whether if it was pneumonitis or colitis or cardiac myocarditis, and then looked to see how many of those patients that died from that syndrome had other overlapping concomitant toxicities. And actually, it was a lot. So you can see that there's a great degree of overlap, and that when you have one of these rare toxicities or lethal toxicities, it's often in concordance or accompanied by many other toxicities that are occurring all at the same time. And it's very interesting that patients will often die from one toxicity and not others when there are multiple ones that are going on. But usually the cardiopulmonary axis or the neurocardiopulmonary axis is one of the areas where I'm most nervous about when a patient has a toxicity because of the rates of fatalities there. And we'll go through that a little bit more in details. But also what was interesting in this paper that they looked at of these rare fatal toxicities from immunotherapy is that over time, I think due to the large number of patients treated with PD-1 and PD-L1, the number of fatal immune-related adverse events is certainly increasing, whereas ipilimumab is decreasing. One could look at this with rosy-colored glasses and optimistic eyes and say, well, we're getting better at treating ipilimumab toxicities because it's the oldest checkpoint inhibitor, and maybe that's why the fatality rates are going down, but we need to do better at PD-1 and PD-L1 management. This was a slide that Dr. Bass showed briefly in the prior talk, but just to expound on this a little bit more. On this plot, you can see the incidence of the immune-related adverse events, as shown here by the bars going to the left, and then how many of those adverse events were actually fatal with the darker blue bars going to the right. And one can see here that colitis is very common when you're treating patients with checkpoint inhibitors, but fortunately the fatality rate is lower. But when you look at something like myocarditis, that's thankfully very uncommon, yet the fatality rate is very high. So I think in some of these rare toxicities like hematologic toxicities, myositis, they don't happen very often. They're at the very bottom because the left shifted bars here are very low in frequency, yet they can be very fatal. So I'm wondering if is the reason that they're so high fatality because we don't have a lot of experience with them yet because they're so common. That's possible. The other issue is that for some reason when immune tolerance is broken against those particular problems, for whatever reason, it's just much more difficult to control so that the threshold for breaking tolerance is much higher, but once you've gotten there, you're really in trouble. That's another theory about that. And these side effects present within the first 2 months of treatment. So with this curve here, you can see that both with ipilimumab, PD-1, and the combination, most lethal toxicities happen within about a month or two. 40 days median onset for IPI, same with PD-1. And the combination, these lethal toxicities present with symptoms within a couple weeks of treatment. So most of them happen early. Thankfully, if patients have been on treatment for a very long time, it's very unlikely that they'll later develop a lethal toxicity. So that's one issue. We need to do better understanding why these different toxicities happen. I talked about this kind of more in the prior talk, so I won't go into too many details about it here, but this is just a general summary of all the different mechanisms of why some of these fatal toxicities are happening. Myocarditis, I think, is one of the fatal toxicities that we're trying to understand a little bit more than the other ones, or at least the correlative science is a little bit more advanced in my mind, in that there have been T cells that recognize particular antigens, both that are expressed in the tumor as well as in the myocardium, and there have been studies where the T cell receptors have been cloned and same T cell populations are recognizing these. So as we get better at knowing some of these antigens, hopefully we can have a better understanding of who may be likely to develop myocarditis and who may not be, so that we can help better patients. And this seems to be a very T cell directed process, so if we think of ways to suppress T cells in different ways other than steroids, because unfortunately steroids is not sufficient enough in many cases. IL-17 and other cytokines have been associated with fatal GI toxicities, and this is just another plot showing how patients that have certain toxicity profiles, especially IL-1 driven toxicities, can be associated with significant toxicities, and there are IL-1 inhibitors that are out there that can be blocking certain types of pathways, cytokine-driven pathways, with the hopes to prevent some of these toxicities from becoming as bad as they are. This was just a slide I showed in the earlier talk as well, but really showing again that some of these endocrinopathies, which we talked a little bit about hypophysitis in our prior session, I think are related to expression of the target, so CTLA-4 in the pituitary gland, for example. And there have been both cellular mechanisms, and shown here on the top and middle row are different cellular populations infiltrating the pituitary gland in CTLA-4 treated mice. And also antibodies have also been raised against pituitary targets. So this is not only a process that's due to CTLA-4 expression by pituitary cells, but also likely due to antibody development against various pituitary cells. So both T and B cells are probably involved in the mechanisms of hypophysitis. Now, this is an interesting example where a preclinical mouse experiment was able to try to recapitulate what might be happening in patients. And one of the challenges for our toxicity understandings in general is that a lot of the mice that you give checkpoint blocking antibodies to, be it CTLA-4 blockade or PD-1 blockade in a therapeutic setting for these mice, they don't really get the same types of toxicities that patients get that get these immune side effects. So that makes it difficult to study some of these toxicities. However, the mice that genetically lack these immune checkpoint receptors altogether, they do develop toxicities. And it's very interesting that PD-1 null mice have a lot of myocarditis. And so what that can teach us about what's happening in T cell processes that are infiltrating the myocardium in patients that develop myocarditis is going to hopefully be very, very helpful as we get better at trying to treat fatal myocarditis. The last little example I'll give here is a way that just came out. This is another kind of interesting anecdote from Doug Johnson's group, where a patient with really severe myocarditis was treated with a CTLA-4 agonistic drug. And this is just a mechanism of reminding us how CTLA-4 works, or at least how we think CTLA-4 works, which is by inhibiting T cells early in the immune response. This is showing basically a T cell getting co-stimulated by B7 and CD28, and many people think CTLA-4 works by outcompeting with CD28 for the B7 molecule, but there are a lot of other ways that CTLA-4 blockade might be working, including a lot of controversy over whether T cells or CD4 T regulatory cells are depleted by CTLA-4 blockade. So it might be something with T regulatory cells. But I think the bottom line is that if you use abatacept, basically to agonize CTLA-4, which is the reverse of what we're doing with ipilimumab, in this case example of a patient with really significant myocarditis, one can see here that this patient improved with CTLA-4 agonism, and that myocarditis that was present, this patient had chemotherapy and then PD-1 for lung cancer. At day 0, this is when their myocarditis began. You can see troponin really increasing very high, troponin T, and creatine kinases very, very high. This patient received intravenous steroids and oral steroids throughout the course as well. But what was interesting is with CTLA-4 agonism, this patient ultimately improved. And so this is raising some question about, well, if you're agonizing CTLA-4, could that reverse the favorable anti-tumor immune effects you're trying to get with blockade of CTLA-4? I would say in the case of myocarditis, which I showed before, which can be incredibly fatal, it's most important to try to get through the side effect and not necessarily worry about the anti-tumor effect if a patient has as bad a myocarditis as they did in this case series. But it really suggested that this might be an interesting way of treating some of the side effects of just reversing the mechanism of what you're trying to do. So with that, I'll summarize. Immune-related events, including pneumonitis, can be fatal. Thankfully, that's very, very rare. Not necessarily any worse than other common oncologic treatments, including many chemotherapies. So though we need to be aware of it, it's not a reason to shy away from treating patients with these life-saving drugs. And then mechanistic insights into why these develop. I gave the myocarditis example, could be something that drives new immunotherapeutic strategies. And I didn't talk about this, but I know this will be part of the session, is the importance of patient and provider communication and education about what to look for when patients are receiving these drugs so that we can mitigate toxicities at their earliest onset. So with that, I'll thank everybody. This is our melanoma group. I put our 2 newest faculty members in the box, and then I realized Mario wasn't there for this picture that day. So I put you in there too, Mario. So we need to take another picture where you're included. Thanks again for your attention.
We have 2 or 3 minutes for questions. We are on time, yeah. Yeah. Can you identify yourself?
Yeah, Jeff Crawford at Duke University in lung cancer. So to us, pneumonitis is maybe a bigger deal than it is in the melanoma population. We have a harder time diagnosing it because of all the underlying problems. We've got patients with bad lung disease to begin with. We now treat everybody with PD-1 drugs post-radiation. And so we have a radiation pneumonitis and then the immune pneumonitis on top of it. So in short, it's a problem. And what I'm wondering from your perspective, you say it's kind of a rare event to be fatal, but the slide you showed, there's a significant death rate, right? So if you look at that, that looks like 15% fatality rate. And maybe that's coming from our population more than the melanoma population. That's question one. And then question two, do you re-challenge patients or not if they develop pneumonitis?
So yeah, great points, and I agree. I do think the lung cancer patient population is, in general, I think a lot sicker. Melanoma patients tend to be a little bit younger and don't have other comorbidities too. In terms of the fatality rates, so among patients with pneumonitis, as we see here, that's correct. There is a decent fatality rate of approximately 15-ish%. I think if you look at just people that have pneumonitis and then you multiply that by how many of those are actually fatal overall among all the patients that are treated with the checkpoint blocking antibodies, it's rare to die from pneumonitis. But yes, if you have it, then the fatality rate is not insignificant. It is significant, as we can see here. So thank you for that clarification. In terms of the re-challenge possibility, do you re-challenge? I feel comfortable re-challenging grade 1 pneumonitis for sure, because we could see that most of those patients got better. Grade 2 pneumonitis, I'm a little bit more hesitant to, and it depends on the patient situation and how many other opportunities you have to treat them. I think it's a case-by-case decision, so it's really hard to kind of say I treat yes or no in these kinds of situations. In the paper that was published among those 43 patients, there were cases of recurrent pneumonitis. I don't remember the details exactly among how many of those recurrent pneumonitis cases were due to re-challenge of the drug versus recurrent anyways, which can happen even after you taper the steroids without additional drug. So I think the details need to be parsed out, but pneumonitis can certainly recur with or without re-challenge of drug. And it's just a clinical gestalt feeling about whether you feel safe to redo it. And I would definitely retreat a grade 1 pneumonitis, perhaps less for other grades. And because we know from at least Ipi/Nivo, the responses that patients have, and I'll show this in the case discussion that we have later, seem to persist with discontinuation of drug, at least in melanoma. So the question of do you even need to retreat remains an open one, and I'm pretty hesitant, at least certainly for grade 3 pneumonitis. Grade 2 is a little bit of a gray zone.
One group that is problematic is the patients that are getting adjuvant now treatment with durvalumab, that they got chemoradiation. In terms of pneumonitis, I think the incidence is higher also.
Right, yeah, I don't know the details directly because we do adjuvant PD-1 in melanoma differently than after chemoradiation for lung, for sure, but adjuvant is especially important to be mindful of that. And in my mind, in general, in adjuvant settings, I have a much higher threshold to think about re-challenging someone that had a significant toxicity before.
Yeah.
Thank you very much,
Anyway,
Mike.
yeah, let me